My name is Sydney. I'm a current research assistant for the Department of General Surgery. Thank you for joining me while I share a collaborative project from Stanford's Trauma, Emergency Department, and Wellbeing Leadership, titled Team-Centered Care After Trauma Patient Death, Promoting Healers' Healing by Humanizing Our Roles. We designed and launched this project with support from Stanford UL. So first, we investigated the current literature surrounding vicarious trauma and recognized that recurrent exposure to adverse events such as patient deaths have cumulative physiological and emotional impacts on all individuals of the care team. This may lead to increased risk of self-isolation, burnout, and ultimately negatively affects personal and professional well-being among clinicians. Here we wish to share our progress with an ongoing 3-month wellness intervention pilot, which will reach conclusion at the end of April. The goal of this project is to acknowledge the impact of caring for trauma patients who die in the trauma bay or operating room, despite resuscitation efforts. Our aim is to connect with each team member involved in the care of these patients to offer resources, support, and express appreciation for their dedication to this community. To establish a workflow for reaching these individuals, we followed a Plan, Do, Study, Act methodology. After each patient death in the trauma bay or operating room, we extend a personalized email to each member of the care team. This communication includes a 1-page mental health resources document with contacts for leadership and peer support, an enclosed $15 coffee gift card to encourage taking a personal moment or debriefing with a colleague if more comfortable, and also an invitation to attend monthly healing sessions facilitated by a grief counselor. This pilot also offers a framework for facilitating a pause and diffusing session immediately after patient death. Throughout the pilot, we are measuring engagement based on email responses and healing session attendance. And workflow was evaluated at just about the halfway point of our timeline, right after event number 6. And at that point, we focused on revisions to the resources document, condensing to 1 page, and also reducing the event to email distribution time to 72 hours or less. This is considered to be a time for critical impact for communication. Currently, at just over 2 months post-launch, we've recorded 7 trauma mortalities and have sent 100 emails. Our average time from adverse event to communication distribution is about 89 hours and accounts for the time spent gathering a comprehensive list of the patient's care team and also confirming accurate contact information for these individuals. So far, we've received 17 unsolicited positive email responses to our communications, some examples of which can be seen here in Table 2. And we also continue to receive in-person feedback from various clinicians this project has reached. Additionally, we've had 2 monthly healing sessions with 15 and 10 individuals in attendance, respectively. All members of the care team are welcome to attend. We've had several nurses, physicians, technicians, and social workers attend so far. We also plan to continue these sessions ongoing after the pilot concludes. So from the responses and the feedback we've been gathering, we are seeing very encouraging positive impact from having an organized support system in place for care teams involved in patient deaths. We've learned that creating space for regular and facilitated peer-to-peer discussions is opening the door for a multitude of different opportunities for impacted care teams to receive the type of healing support that they feel is most beneficial to their needs. And also from this project, we realized the important role that immediacy of support can have on care teams, especially when paired with varied options to suit personal preference. For future iterations, we may also consider incorporating objective well-being measurements to study longitudinal impact. This could be done by implementing survey-based check-ins to evaluate satisfaction with current efforts and also allows room for further improvements. Additionally, transitioning similar efforts from pilot to daily workflow may benefit from slow integration into an already established routine or adoption by wellness teams. And that concludes our progress so far. Thank you for watching.